Welcome everyone to today's program. I'm Anuja Vaidya with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Dr. Julie Servos is the Medical Director of Gastroenterology and board-certified gastroenterologist and internist. Dr. Servos serves as the Associate Dean for Diversity, Cultural and Student Affairs and Associate Professor of Clinical Biomedical Science in the Charles E. Schmidt College of Medicine at Florida Atlantic University. Her extensive research experience includes positions at the University of Southern California Medical School, the University of California at San Francisco, the Howard Hughes Medical Institute at Stanford University, and the Massachusetts General Hospital. Dr. Servos has published numerous articles and abstracts in top-tier journals and has presented her work at various research and medical meetings. Dr. Servos is licensed to practice medicine in Florida. Dr. Elliot Ellis is a team lead for gastroenterology. Dr. Ellis is a board-certified gastroenterologist with the Digestive Center of the Palm Beaches. He is currently practicing in South Florida with offices in West Palm Beach and Palm Beach Gardens, Florida. After receiving his undergraduate and medical school degrees at the University of Pennsylvania, Dr. Ellis completed his internal medicine residency at Yale University. Dr. Ellis went on for fellowship training in gastroenterology and hepatology at Mount Sinai Hospital of New York. Erin Detry is product manager for GMed, a modernizing medicine company. Knowing medicine was her calling, she graduated with a master's in health science in 2000. After a decade of practicing gastroenterology as a physician assistant, she traded the art of practicing medicine for the art of EMR system product development, joining GMed in 2011. Completing her Master of Business Administration in 2014 and transitioning to modernizing medicine in 2015. Her product focus translates academic guidelines into practical, scalable analytics solutions with the goal of improving a practice's operational, financial, and clinical health. It is now my pleasure to turn the floor over to Julie to begin today's presentation.
Thank you very much, Anuja. This is Julie Servos. Thank you so much for joining us on this webinar. I'm going to begin with a background on the origins of the Triple Society paper. In 2006, the American Society for Gastrointestinal Endoscopy, or the ASGE, as well as the ACG, formed a task force on quality in endoscopy, and they published their first version of quality indicators for colonoscopy. Subsequently, in 2015, these quality indicators were updated and represent the current indicators that GI endoscopists should use in the quality improvement process. I've listed the reference for all of those who would like to look it up thereafter. Now, the purpose of identifying and measuring these quality indicators are several-fold. The first, improving patient care by identifying poor performers and retraining them or removing privileges if the performance cannot be improved, are certainly readily identifiable purposes for these measures. An example would be the adenoma detection rate, or the ADR, which I'm sure many of you are familiar with. The most effective interventions to improve ADR include two areas of education. First is the Paris classification, or understanding flat and depressed lesions could represent adenomas, as well as a review of the withdrawal techniques, such as probing, proximal size of folds, cleaning up pools of retained mucus, and ensuring adequate distension of the entire colon. Other interventions include technical adjuncts, such as chromoendoscopy. Now, the development of the quality indicators took place with the task force. They summarized current evidence and then focused on parameters related to endoscopic procedures. The quality indicators were then graded by strength of evidence. As with all other recommendations, the grades of evidence go from 1A to 3, where 1A is the strongest, most clear benefit demonstrated, and the strength of the recommendation is high. As you can see on the slide in front of you, the grade of recommendation of a 1A is the strongest, and those include randomized trials without important limitations. As we go down the slide all the way down to 3, 3 is really unclear benefit, and that's really based upon papers of expert opinion only. So again, we're looking at grades of evidence from 1A all the way to 3. With respect to the development of the quality indicators, each quality measure is classified as an outcome or a process measure. Specifically, an outcome measure assesses the result of care. For example, prevention of colon cancer by screening. These are clinical outcomes. Process measures, on the other hand, assess performance during the delivery of care. For example, the adenoma detection rate or adequate biopsy sampling. It's important to remember that these are quality indicators and not measures that we will discuss. And what I mean by that is a quality indicator is the parameter being used to compare the performance of an individual or group of individuals with an ideal benchmark. So we're looking at ratios and percentage of performance, percent achieving goal. Each of the quality indicators we'll discuss has a performance target. And the targets are set from benchmarking data in the literature when available, listed as NA or not applicable when no data is available, or if there's expert consensus considered failure to perform a never event, then the target level is set at greater than 98%.
Thank you, Julie. So quality indicators were basically divided into 3 categories and essentially 3 time frames. There are pre-procedure quality indicators, intra-procedure indicators, and post-procedure indicators. The task force mentions and basically recognizes that there are central quality indicators that are common to all endoscopic procedures, and these are listed below. I'm not going to go through all of them quickly. I'm going to go through all of them quickly because I'm going to focus mostly on the colonoscopy specific indicators that are new to the task force's guidelines. As you can see, common to all endoscopic procedures for pre-procedure quality indicators include things like indication, is informed consent obtained, frequency with which the pre-procedure history and physical are performed and documented, frequency that adverse events are assessed and documented before sedation, the use of prophylactic antibiotics, frequency with which a sedation plan is documented, the talk about antithrombotic therapy prior to the procedure, is a timeout taken, as well as frequency in which endoscopy is performed by a trained and credentialed professional. Specific to colonoscopy itself, there are new guidelines, and these are the ones I'm going to focus on. The first one talks about the frequency of the correct indication. It is well known that when colonoscopy is performed for appropriate reasons, more relevant diagnoses are made, and the performance target for correct and appropriate indications for colonoscopy is listed at 80%. So for example, as long as you are documenting the screening colonoscopy, ulcerative colitis, iron deficiency anemia, anything that we would deem as appropriate for colonoscopy, that would lead to higher performance target rates. The task force mentions that it is very important that we document the date of the last colonoscopy, specifically with regards to indication. If we do not know the date of the last colonoscopy, we should document not available. With regards to specific informed consent, the target rate is 98%, and specific to colonoscopy, the Besides the known risks of bleeding, perforation, and infection, the task force recommends mentioning missed lesions and IV site reactions as part of informed consent for colonoscopy. In terms of indications and correct screening intervals for screening colonoscopy and post-polypectomy screening, as well as post-cancer screening, the target recommended is 90%. Specifically, the task force mentions that many gastroenterologists and surgeons performing colonoscopies recommend average risk colonoscopy follow-up at 5 years. They mention specifically that this is not cost-effective and exposes the patients to increased risk and generally have low yield. The last pre-procedure quality indicator is whether or not appropriate colonoscopy intervals are performed for patients with ulcerative colitis and Crohn's disease, and Crohn's colitis specifically. A 90% performance target is recommended. Specifically, ulcerative colitis should have colonoscopy surveillance starting at about 7 to 10 years after the onset of symptoms. With regards to Crohn's colitis, this is true as well, as long as 1/3 of the colon is involved. Every 2 to 3 year follow-up is appropriate during the first 20 years, but may be more appropriate to do yearly follow-ups for patients who have higher risk, such as those with primary sclerosing cholangitis, or patients who have significant findings on their colonoscopies, such as cobblestoning, scarring, and chronic severe inflammation. In terms of intra-procedure quality indicators common to all endoscopic procedures, you can see the list below. Photo documentation is mentioned, frequency with regards to sedation monitoring, the use of IV meds and reversal agents, as well as whether or not the procedure needed to be interrupted. Specifically for colonoscopy, the task force mentions the quality of the prep. The first question is, does the gastroenterologist or the proceduralist document the quality of the prep at all? And the target performance is 98%. In the past, it was recommended that prep quality was talked about in terms of excellent, poor, or fair. Now it's more talked about in terms of adequate or inadequate, with an adequate prep being a prep that can identify polyps greater than 5 millimeters in size. The next indicator is whether or not you are obtaining at least 85% of patients for colonoscopies with adequate prep. If over 15% of your patients have an inadequate prep, it's probably time to change practice habits and possibly consider split dosing preps. Cecal intubation with photography is a priority indicator, with over 95% of patients with screening colonoscopies recommended as the target for cecal intubation. They specifically mentioned that photography is very important for many reasons, medical legal being one of them. Low cecal intubation rates have been associated with higher rates of interval colon cancer. Adenoma detection rate is another priority indicator, and probably the most important. It is the single most important quality measure in terms of colonoscopy. It is known that doctors who find polyps in less than 10% of their colonoscopies have a greater than 10 times likelihood of those patients developing a post-colonoscopy cancer. 25% overall detection is recommended, but specifically 30% for males and 20% for females. Withdrawal time is important to document, with the goal being greater than 98%. And again, the whole idea is that patients and doctors who have longer withdrawal times find higher adenoma detection rates. Average withdrawal time, as mentioned, should be over 6 minutes. They also mention that for patients with chronic diarrhea, biopsies should be taken in the right colon and the left colon to rule out microscopic colitis, and that the target performance should be greater than 98% for patients undergoing colonoscopy for chronic diarrhea. Similar target rates are recommended for surveillance in high-risk patients with colitis. Every 10-centimeter biopsies in 4 quadrants is recommended for surveillance purposes with a goal of 98%. The last intraprocedural quality indicator is that of an attempt at polyp removal for polyps less than 2 centimeters. This is with the goal in mind to try to avoid unnecessary surgeries. So polyps under 2 centimeters should be attempted to be removed during the colonoscopy with a goal of 98%. In terms of post-procedural quality indicators, common to all endoscopic procedures, nothing too surprising, documenting of patient instructions, whether or not there was a complication, an adverse reaction, patient satisfaction data. But specific to colonoscopy, there are targets with regards to complications. Incidence of perforations should be less than 1 in 500 colonoscopies, all comers, and less than 1 in 1,000 for screening colonoscopies. The incidence of post-polypectomy bleeding should be under 1%, and the ability to manage a post-polypectomy bleed without surgery should be greater than 90%. Very important, and a priority indicator is number 4 on this list. The appropriate repeat colonoscopy recommendation should be greater than 90%. This is where pathology results come into play, and we will talk about this more later on. To summarize, implementing quality improvement process for endoscopists, quality indicators have been identified. Practices must have the ability to assess how each endoscopist does, and even perhaps make a scorecard. Quality indicators must be measured and tracked. And then once indicators or outcomes are measured, a practice can respond with a plan, implement the plan, and remeasure outcomes. This becomes the practice improvement cycle.
And this is Erin Detry. I'll take it from here. So this practice improvement cycle becomes a bit tricky because you need to be able to understand where you are and understand where you're going, but also be able to assess what areas you may need more work in and have plans for improving the areas of deficiency. So I'm going to take you through one possible way of looking at your data that we on the GMed Modernizing Medicine side use analytics to help with this. We've developed a product called G-Insights. G-Insights evaluates your quality indicators every night and gives you an idea of where you are and allows you to drill down by your enterprise, by your location, down to the provider, and even down to the patient level, and look at things by month, by quarter, by year, or even by a day to see how you are meeting or exceeding the Triple Society quality metrics. This is an example of our colonoscopy quality report card, showing you from an enterprise even down to a physician level, the measures, each measure documentation, the measure number, and your performance based on current year, quarter, year, and last year. Green obviously meaning you're meeting or exceeding the guidelines in place, yellow meaning you're right at the borderline, and red meaning that you are failing. This allows you to doctor by doctor look for your weak points, and doctor by doctor and facility by facility make a practice improvement plan. You can see if there's trends within a particular set of scopes or trends within a particular facility or a particular set of doctors. What you want to be able to do is look at where you are. Like, for example, 2013, this is interval screening, so appropriate screening metrics. Are you recommending a 10-year follow-up? Are you recommending a appropriate colon polyp follow-up? You can see that this practice was below goal in 2013 and even dipped lower in 2014. They made a practice improvement plan in 2014, and immediately 2015 see their numbers go clearly above goal, except for that one outlier who perhaps did not attend the in-service that day or had strong feelings against the in-service that day. But it's this level of granularity that you need to be able to track measure by measure. And in this case, it looks year to year, but you should also be able to look at this quarter by quarter and month by month as well. Here's an example of tracking the withdrawal time. Each bar represents a physician. You can see that most of the physicians are in the 9 to 10 minute range. You can see one particular physician tracking at about 5 minutes and 42 seconds. You need to be able to plot your providers against the national benchmark of 6 minutes, the established practice benchmark that you can decide. Look at where each provider lands with your practice average. And then we also provide you a glance into what we call the G benchmark or G average. That's the average of our GMed community over time. So you can see where each of your doctors and each of your facilities can stack up with all of these metrics. You can use this to create an adenoma detection versus withdrawal rate. You can clearly see here that as the withdrawal time goes down, adenoma detection rate goes down as well. Each bubble represents one of your physicians, and you can begin to add and subtract parameters, perhaps different scopes, different rooms, different preps to determine what things are contributing to a better quality indicator profile than others. Here's another example of a particular practice who they had a challenge with the adenoma detection rate, likely not because they were poor endoscopists, but more that they were poor record keepers, so to speak. So they had an incentive program to document well within the medical record post-pathology and immediately saw month to month their ADR trend upwards. Then you can see they kind of lost their edge and started to trend back down a bit in January. But it's this immediate response that allows you to plan, reassess, execute to give you that information at an immediate basis at your fingertips. So the cycle is understand your practice, assess, create your plan, implement your plan, evaluate your outcome, but continue to reassess and use a tool that allows you to make those reassessments at the most granular level with the least amount of manual entry.
Great, thank you, Erin. This is Julie once again. So to summarize what my colleagues and I have presented over the last half hour approximately, first, the Triple Society paper provides the current indicators that GI endoscopists should use in the quality improvement process. Quality of patient care will drive government and industry reimbursement over time. Practices will need to know and react to their quality outcome data before it negatively impacts the practice's bottom line. And finally, you can promote and leverage your data to differentiate your practice with referring physicians, payers, ACOs, hospital systems, and CMS. Thank you very much. And I think at this time, we will look at questions that have been submitted to us.
Yes, thank you to all our panelists for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A. So the first question that we have is, how do practices track their ADR? Does this require manual entry when the pathology returns?
I'll take this question. This is Erin. On the GGastro platform, when the pathology result comes back, it currently comes back as a flat PDF. Typically, then either the physician or the medical assistant does need to use the GI Quick or G-Quality pop-up to select the final pathology reading. However, I must say that we are in development and actually in beta with what we call an automated adenoma detection flag, so that that information can be automated to come from the pathology department with your pathology department's assistance to auto-complete that field. That should help tremendously with more accurate ADR detection rates.
Great. We also have another question for Erin. How can I track the quality metrics based on scope type or even individual scopes?
Yes, whatever solution that you utilize or choose to utilize to track your information, you need to have the ability to track against your scope or scope manufacturer. We're seeing a lot of new players into the scope arena and a lot of new add-ons to the scope features. So however you design your quality metrics for your facility, you need to have the ability to review by scope type. This is part of the G Insights platform as well.
Okay, great. Our next question is, the frequency of correct indication in colonoscopy seems a bit low at 80% target. Why the low target?
I'll take this one and promise I'll let everybody else answer the next ones because I remember doing research on this one. The 80% threshold for correct indications was based off of a very large multi-center study where they looked at colonoscopies from both the UK, Europe, and the US and determined that around 28 to 30% were done for questionable indications. So they took that piece of information and said it's too difficult to go from 28 to 30% questionable down to 98% or 2%. Let's find a good place to start, and that's where the 80% correct indications came from. I'm sure that in future reiterations of this, it's going to become even more and more closer to the 98th percentile. All right.
Okay, great. Our next question is, do you suggest the same quality indicators for surgeons as for endoscopists?
Absolutely. I'll take this one. Yeah, I think anyone who's doing colonoscopy should be put to the same quality parameters. Everyone's trying their best to take care of patients, and it doesn't matter to the patient whether or not it's a surgeon or a gastroenterologist performing the case. Quality is quality.
Excellent. So now we're actually coming up to our last question. If anybody else has questions, do remember to just type them in. Our next question is, when recommending colonoscopy follow-up, is it appropriate to choose the option to decide after biopsy results or not needed at this time?
Well, I think part of the guidelines are suggesting that one of the priority quality markers is appropriate post-procedure recommendations. So I think it's very important to specifically look at the pathology and decide on the recommendation based on the pathology results. So it's okay to potentially write follow-up on biopsy results, but then the definitive recommendation should be based on the pathology results.
Okay, great. And we have one final question here. Is G Insight an additional cost?
It is a slight cost subscription per month. We are currently offering a no obligation 90-day trial, so you can try it out to set it up, and if you don't find that it adds value, you can discontinue it after the 90-day trial.
Okay, fantastic. Fantastic. I would like to thank our presenters again for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.